Hey everyone, I'm Dr. Diana Bitner from True Women's Health. Really excited to be here tonight. I would love to know if you're all out there, because otherwise it's me talking to my face on a screen. So I'd love to know you're here. So please feel free to put in comments in the chat. I'll be watching, and Missy and Sam will be watching behind the scenes. I'm so excited you're here to have a conversation around breast cancer awareness. This month is Breast Cancer Awareness Month, and we really want to talk about screening. We get lots of questions about screening every day when we see people for their annual exams or their Waypoints visits to discuss cancer risk. We're always talking about what screening is appropriate for you. So we really want to bring in the concept of screening for women who are at normal risk or low risk for breast cancer versus women who are at high risk. That's the first difference that I want you to take away with. And so, we know there's a lot of confusion, but first to start with that discernment. Then we want to get into talking about the study that's out there called the Wisdom Trial. Now, I am not, and True is not officially associated with the Wisdom Trial in any way other than we think it's a really great idea. I first met the Wisdom investigators at the Menopause Society meeting last year in October of 24. And I was very intrigued because what the Wisdom Trial looks to do is understand what is the best method to screen for breast cancer. There are many societies that make all different recommendations for what a woman should have in terms of screening to optimize finding a breast cancer early versus finding it, unfortunately, later or not finding it until it's later. And then there, of course, are more consequences with the need for more treatment, more invasive treatment. If a woman is going to get breast cancer, of course, the goal is to find it early. And if we find it early, hopefully even so early it's not even created an invasive cancer, then we can treat it without hopefully chemotherapy even, and potentially with just an endocrine blocker, et cetera. Point is, we want to screen. How do we do this? And so all these societies make different recommendations. There's the National Cancer Institute. There's American College of OBGYN. There is the NCCN. So there's these different guidelines. And then in Europe, it's different. So the basic guideline is here in the US for women who are at low risk to start screening at 40 and every year thereafter. In Europe, it's every 3 years. Again, we don't know the right answer. And so the Wisdom study looks to figure that out. Are some women okay with every year? Are some women okay with every 3 years? Do some women need every 6 months with an ultrasound and MRI or MBI or contrast enhanced mammogram? So we're going to go through each of those modalities. So I think we should first start out with a video. The Wisdom investigators were not able to be here tonight, so I think it's great to start out with a video that really explains the Wisdom study and why we're so keen to be recommending that you might sign up for this.
Knowing how often to get a mammogram can be really confusing. That's why scientists and doctors designed the Wisdom study. We need your help. We'd like you to consider joining a clinical study to test which approach to women's breast screening is better. It's simple. We want to find out if all women need to get a mammogram every year, or if it's better to personalize how often women should be screened based on their individual risk. Here's how it works. There are 2 groups of women in the study: the annual screening group and the personalized screening group. Keep in mind, you receive good care regardless of which group you're in, and no study participant is advised to be screened less frequently than the current recommended guidelines of the U.S. Preventative Services Task Force. If you decide to participate in the study and are in the annual group, you're asked to get a mammogram every year starting at age 40. This has been the standard for the past 30 years and is the guideline recommended by some professional organizations. If you're in the personalized group, you're assigned your own personal screening schedule based on your medical history, family health history, lifestyle, and genes. Some women in this group are advised to get a mammogram every year, some more frequently and some less frequently. Women at higher risk for breast cancer in either study group may be offered additional services with our Athena Breast Health Specialist. If you decide to participate in the study, you're asked if it's okay if we randomly assign you to a group. That means you're assigned to one of these two groups purely by chance, like the flip of a coin. That's the best way to answer a scientific question like this without any bias. We know that some women may not feel comfortable having the choice made for them, so those women can choose which group they want to be part of, either annual or personalized. Here's how to get started. Carefully read the informed consent and consider the information in it. If you decide to participate in the study, simply complete your registration, a brief health questionnaire, and agree to be randomized or select your group. Next, complete the consent and authorization form. This lets your doctors know about your participation and allows study personnel to access your medical records, get your mammogram results, and check on your health in the future. If you're in the annual group, that's all you need to do to join the Wisdom study. If you're in the personalized group, you receive a saliva kit in the mail from our study partner, Color Genomics. Simply activate your kit online, collect your saliva, and mail it back. That's all it takes to get enrolled. About 6 weeks later, you can view your saliva test kit results in the secure part of the Wisdom website. We send you an email to let you know when your results are ready for you to review. For both groups, this is also where we send your mammogram screening recommendation, and you can always log in here to see your study progress and review your documents. Here's what to expect along the way. The main study lasts 5 years. Participation is easy and can mostly be done from home. There are no study visits, doctor's appointments, or additional lab tests. Every year, we send you a questionnaire to check on your health and to update your personal and family history. When you're due for your mammogram, we send you a reminder email. With your participation, we hope to answer important questions and end the confusion about how often to get a mammogram. We hope you choose to be one of the 100,000 women who will help us find a better way forward and improve screening guidelines for you, your friends, sisters, daughters, and future generations of women. Please join us today.
Okay, so I hope that's helpful, and you can probably see why I'm so keen on being involved in this. Missy, is it all okay on the camera? There we go. So again, please let me know any questions you have as we talk about this. I was on Fox 17 this morning talking about different screening modalities. So I would just kind of like to review a little bit the different options for screening. So the screening that most of us know about is called a mammogram. And if you don't know, mammogram uses X-ray technology. And what we're mainly looking for with a mammogram is there a presence or absence of calcifications? If there are calcifications, there's several different patterns. So what the body does when there's inflammation, such as inflammation around a starting early cancer, is there's inflammation created and the body wants to put calcium around this to wall it off, essentially. It's a reaction to the inflammation. And so what happens is that the calcium that happens in a very early breast cancer, like what we call a DCIS or a non-invasive breast cancer, is that there's these little punctate calcifications, and that can be a high-risk area where a biopsy would be indicated. Mammogram can detect masses, but it's not that sensitive, and it could miss up to 10% of masses that are present in a breast if there is a mass. The mammogram can also be limited by breast density, but the mammogram is the best way to tell how dense your breast is. When you do get a mammogram report, there are several things I want you to look for. Number one, what was the category of concern? So there are 5 categories of what's called BI-RADS. BI-RADS is a category that you'll get that tells us your level of risk as discerned by the mammogram. A level 1, BI-RADS 1, means looks great. Don't see anything of any concern. Everything was seen. The density is not an issue, and we'll see in a year. Looks great. Very low risk. A BI-RADS 2 means, there's a little density, but we don't see anything of concern, and very likely you're fine for a year or more, and we recommend that you come back for an annual mammogram. A BI-RADS 3 means, there's something that looks benign, but we're not 100% sure. And the best thing is to look at it again in 6 months rather than in 12 months. So BI-RADS 3 means curious, but not concerning, but curious. Let's look at that a little bit closer. And for sure, again, mammogram in 6 months. If it's a BI-RADS 4, that's a suspicious finding. That means that likely a biopsy is recommended. Category 5 is this very much looks like a breast cancer. It definitely needs further testing, likely biopsy for confirmation, but we've got to get things going. A category 0 means incomplete, that they can't quite see because of perhaps breast density. And so we need to do further imaging. So that's BI-RADS. That's the risk score that you get from this. Not the risk score, sorry, but the assessment from the mammogram. The other thing that's important on a mammogram report to look for is your level of density. A level A means the breast is not dense, that everything can be seen easily, that it's mostly been replaced by fatty tissue. And this can happen especially in a woman who's in menopause, not on hormone replacement therapy, and the breast has mostly been replaced by fat. A category B density means that there's some scattered density, but nothing that likely interferes with seeing a small mass or breast cancer, but there's some density. Category C means heterogeneously dense, meaning it's dense and not dense and dense and not dense, but there's enough of it there that it connotates more risk, that it might be difficult to find a breast cancer, and even connotates more risk in that the breast personality might be different. The individualization of the tissue is that it's maybe more active. There's more growth factors. And so we might want to look a lot closer. And category D means extremely dense. It's really hard to see anything. And we know that that connotates increased risk for breast cancer. So those are the things we're looking for in a mammogram. An ultrasound is where sound waves are used to discern fluid levels. So is a collection of tissue, is it a cyst, meaning it's fluid filled? Is it a complex cyst, meaning there's solid areas and cystic areas? Is it a solid mass? And the ultrasound is the best way to tell, let's say, normal breast tissue, fibrocystic breast tissue versus a mass, certainly a mass that might be concerning. A molecular, molecular-based imaging is where certain dye with a PET scan is used. It's not something that I'm very familiar with. In fact, I had a patient mention it today. I'd seen some other information written about it. It's nothing I've ever ordered. I think it's quite new. Again, I've never ordered it, never seen a report. So it's awesome that people are looking at more and more ways. And it's something that we would use if an MRI is not available or not deemed safe, if we need more information and an ultrasound isn't giving us what we need. An MRI, of course, is using magnetic resonance. And usually when an MRI is done for assessing a person who is at high risk for breast cancer, it's done with and without contrast. And then there's the contrast enhanced mammogram. This is something that also uses a mammogram with dye. A woman is given dye in her vein, and then she's quickly up into the machine, a mammogram, and 6 minutes later, another mammogram. And again, it allows us to see the breast tissue before and after the dye to better discern what that tissue looks like. So let's get to Laura Libner. So Laura, I miss you. Hope you're well. And thank goodness for screenings. The MRI once a year and 3D mammogram. Your breast cancer was caught just a week ago and stage 1. So Laura, I'm so sorry you have to deal with this. I'm so glad that it was caught really early, and I know that you're going to get good care, and thank goodness you're on top of it. So thank you for staying up to date with your screening. And the good news about stage 1 ductal carcinoma in situ is that likely it can be treated without additional treatment. So we'll be sending lots of light and good wishes, and please keep us in the loop. Thank you for sharing. Vicki, looks like you're asking about just what I talked about, this contrast enhanced mammogram. I think it's a good option for someone whose breast tissue is very dense. The ultrasound is still inconclusive, and we're able to, again, see more information. Is it better than an MRI? I wouldn't be the person necessarily to answer. Too bad I don't have a radiologist right here next to me. But I think it depends, especially if an MRI is not available, if it's cost prohibitive. the contrast enhanced mammogram looks very promising. The contrast enhanced mammogram is also used for people who have a breast cancer and we're looking for a response to treatment, or there's been treatment in the past and we want to see is it growing again, or is there a recurrence? In terms of an AI enhanced mammogram, there's a lot of promise with this. I know there's pilot projects even going on here in the West Michigan community to use AI to look even closer at that mammogram. So again, this is exciting new technology. And it's again looking, let's go back to, do we do screening for women who are low risk, or again, the screening for women who are at higher risk? And when we talk about risk, kind of a good cutoff to think about is your lifetime risk of breast cancer less than 20%, or is it more than 20%? And there are different ways to discern that. But let's talk about the things that you would need to know. And we'll give you the link here in the chat of how you could go and actually calculate your risk score. It's called the Tyrer-Cuzick risk calculator. It's what most of us use to assess your risk for breast cancer. It's something that you can access. And sometimes with a patient, I'll pull out the calculator on the Google, and there it is. And we put in the factors, things that you'll need to know. Number one, of course, how old you are. Number two, how old were you when you had your first child? We know that women who have their first child after the age of 30 are at an increased risk of breast cancer versus someone, comparing the most dramatic swing, at a person who had their first child at less than 20. So we know that risk is there. So something to consider. Number two, your family history. So do you have a family history of breast cancer in a first degree relative, and whether or not they were premenopausal or postmenopausal? And so if it's a first degree relative, that's a higher risk factor. If there's two relatives who are second degree, let's say two cousins that have had breast cancer, then that would increase your risk. It's knowing your breast density. Again, we talked about category A, B, C, D. What is your breast density on the most recent mammogram? And then looking at, are you on menopause hormone therapy? There's a lot of confusion about this. Some risk scales look at that as an increased risk. And I would say from all the data that's come in, we really believe that estrogen does not increase your risk of breast cancer. So that's something that is very controversial. And I don't know, that's a whole nother discussion. But I don't believe, from everything I know, that estrogen increases risk of breast cancer. And so we put all these risk factors together. I do joke, and I want to be really common sense about this. What's the number one risk factor for breast cancer? It's having a breast. Number two risk factor is density. Number three is alcohol. We know that more than 7 drinks a week really does increase your risk of breast cancer. More than 2 increases the risk slightly. More than 7 a week really increases your risk, like a hockey stick. Another risk factor is belly fat. Women who carry extra belly fat, significant visceral fat, does increase your risk of breast cancer. And the last one is family history. How do we determine family history? Number one, from your relatives, right? But let's say you are like me, I'm adopted. I know my birth mother's family history. I don't know birth father. And so I don't know a big part of my family history. The other thing is, what if you're an only child? What if you don't have many relatives? We don't know if that's in your family history because there's not a lot of relatives to tell us that. So what do we do next? We can do genetic testing. And there are many gene mutations that connotate risks for breast cancer. The one that most people have heard of are the BRCA1, the BRCA2. There's also many other genes that show us that you have an increased risk for breast cancer, such as the PALS gene. And most breast cancer screenings here in the office, we order Myriad genetic screening. The Wisdom study you saw uses a company called color.com. Those are both very confidential. Those are not like a 23andMe where other people can find you. And then also there's a new company that we're working with called Sequencing that allows you to look at your entire genome sequence, and then you're kept up to date with updates of what your genome puts you at risk for. So again, all of those put together, again, we go to, are you low risk? And do we stick with potentially the annual mammogram with more screening or do we go for right away high risk breast cancer screening. Here at True, when we calculate your risk and we see that you might be at higher risk, let's say greater than 20% on the tyrocusic, then we would recommend and we would be able to order an MRI with and without contrast. And we have found that insurance has been has been covering these tests without difficulty. So again, depends on if you've paid your copay, what insurance package you have. But again, we see that often those are covered. With a wisdom study, again, it will be very interesting to find what makes a difference. So the women who go into the wisdom study, so I signed up last night. Of note, the wisdom study is currently on hold. They've had such a great interest in being involved in the study that they've had to kind of slow down to make sure that everyone gets good care and gets their genetic kit when they choose to be in the personalized program. And so they're taking names and they're getting to those names as able. If you're out there and you wish to contribute to the wisdom study, they are collecting donations to pay for more people to be able to be involved in the study. But having said that, don't let that keep you from signing up. Of course, the more in the waiting list, then they're more likely to be able to, I think, get donations and be encouraged that people want the study. They're looking to study 100,000 women. And the plan is that once their risk score is calculated using their family history. So again, I signed up last night. I filled out all that information about myself, including the fact that I'm adopted, my level of breast density, my last mammogram, age at first child. I was 28 when I first had Megan. Was I 26? Anyways, I had it right last night. So I put in all my data, and then I'm sure they'll calculate a risk score. They're going to get my last mammogram so they have it. And then they'll recommend, do I get annual screening or do I get additional screening? Then they're going to follow all of us who signed up for the wisdom trial and see what happens. And then they'll be able to better have a risk calculator that includes your family history and your genetics. So I feel like I'm kind of starting to ramble on here a bit. So again, I want to encourage that you take this seriously and really be informed about what might work best for you. At this point, again, feel free to interrupt with any questions. Another question would be, what age should I start screening if I have a family history? Again, it depends. We have to calculate everything all together in terms of your age at first child, whether or not you had children. Not having children at all does actually give an increased risk. So we put that all into the risk calculator and we figure it out. And again, what kind of genetic testing? We talked about that. Going through the questions to make sure I don't forget anything. I like to talk about 5 key takeaways for women. Number 1, that breast cancer screening should be based on your risks, not outdated averages. So again, there's a lot of confusion about this between the different societies. What we'd recommend if you're going to do annual screening is just a screening every year. Again, I guess I want to bring this up. What else do we use to screen? So breast exam is not recommended by societies, but I would recommend a self breast exam and then a breast exam by a provider every year. A lot of women will say, I don't want to do a breast exam because I don't know what I'm feeling. So first of all, I want you to think about breast tissue kind of feels like broccoli. So broccoli, think about like the breast glands are on the outside and then the stem leads to the center. Broccoli stem, broccoli stem. So just think about it as you do your breast exam. And the other thing is that we don't really need you to know what you're feeling. That's our job. Your job is to say, is there a difference? When you examine your breast, maybe 12 times a year, once a month, generally even just a soapy hand in the shower, then you're able to feel, is there actually a difference? Does it feel different now versus it did? Let's say you come in and you say to me, I feel a difference. I do an exam. I don't feel a difference. It doesn't matter. You felt a difference. Let's get additional imaging. If it's been a while since you had a mammogram, then we do a diagnostic mammogram and we add an ultrasound. That will give us the most information when you feel something. So again, we want you to do a self-breast exam. We know that women under 40 who are diagnosed with breast cancer at a young age, the vast majority of women find the mass themselves. So it's so important to do an exam and know your breast tissue. And again, see a provider every year for a breast exam. The other thing I want to caution you against, a thermogram. A thermogram is not safe. It does not tell us any more than me looking at your breast with you dressed in a sweater on. It doesn't tell us any more. It's not sensitive. It's not specific. The theory is that the thermogram detects different areas of heat in your breast tissue. And if an area is warmer, maybe there's a cancer there. It does not work. Please do not spend your money on a thermogram. I've had patients who have had thermograms at different clinics around town or, still out there. And they are like, hey, I've been great. And unfortunately, we do a mammogram. Hopefully there's not a cancer, but I've had too many patients who have had thermograms, felt very comfortable, and turns out they actually do have a breast cancer and or very dense, and there's no way we'd see it. So starting to ramble again, but again, breast cancer screening should be based on your risk, not outdated averages. Anne Marie, let's pop up your question, if you don't mind, Missy, real quick, or Sam. I'm on an anastrozole, which is an estrogen blocker, because I'm high risk. If estrogen is not a risk factor, should I discuss not taking this? A couple things, Anne Marie. So estrogen for a woman who's low risk for breast cancer or has not had breast cancer, taking estrogen therapy does not increase her risk. The fact that you're on anastrozole tells me you're at high risk. And so taking estrogen is definitely a conversation about informed consent. It depends on, again, your breast density. What is your risk factor for breast cancer? That's a really individualized discussion. Now, for some women who really want to take menopause hormone therapy and they're at higher risk, again, it depends on, are you at high risk because of family history? Are you at risk because you have a gene, let's say BRCA1 or 2? Or if you had a biopsy that it actually shows atypical ductal hyperplasia, that's a significant risk. And so again, that's very much an informed consent decision. So I wouldn't pretend to give you medical advice, not having seen you or gone through all of this about what to do. There are some other options in terms of treatment for menopause symptoms. So for example, for some women who are at risk without an atypical biopsy, they might take a medicine like Duo-V. Duo-V is Premarin, again, which was shown in the WHI to not increase women's risk of breast cancer. Women who took Premarin alone actually had a lower risk of breast cancer. And these even were older postmenopausal women. Duo-V is Premarin and bazodoxifene, which is a SERM, a selective estrogen receptor modulator. So like anastrozole, it also can lower a risk of breast cancer. We don't have enough long-term data to know that bazodoxifene is actually effective. I couldn't recommend it to say this for sure will lower your risk of breast cancer, but the two together potentially lower your risk. So again, Anne Marie, this is so much for an individualized discussion with your provider and or a high-risk breast specialist. So thank you so much for bringing this up. Okay. Takeaway tip number 2, the wisdom is leading the way in modernizing screening. So there are several sites across the country, one's in Chicago, but the original principal investigator is in California. So this is a study that really will be helpful in helping us make better recommendations based on risk. Vicky. Sam, do you want to pop up her question? So Vicky, does Wisdom bill your insurance? I filled out the form and it said, yes, it does. It does bill your insurance when they order, let's say, an MRI or a mammogram. If you're high risk, lifetime risk is usually going to MRI insurance getting it. Biopsies and one spot is being monitored. So again, the Wisdom does bill your insurance. They don't pay for you to have an MRI or a high risk screening. I think there are MRIs, let's say, that are cheaper than $9,000. So number one, I'd want you to shop around. A lot of insurance companies will say what an MRI costs at different institutions. Again, I don't know your experience with this, but that $9,000, that's just ridiculous. So I sure hope that you can get good screening and good care and not be limited by your insurance. That's so frustrating. So at least you're being monitored and you've had biopsies. That's good. So again, the Wisdom is there, and we hope that it becomes very helpful. So again, get the full picture. Know that when you read about a new screening modality, is it for a person at normal or normal risk, about 1 in 9 women, or is the screening modality recommended for someone at high risk? So everything matters. Know the full picture. So, at the holidays this year, it's really important to ask people, hey, what have we had in the family? And you might learn more about your family history. Some families just don't tend to talk about family history. Everything is a little hush hush, but we know now that people are talking more and more. So ask the questions, get the answers. Hopefully someone will give you the information. Takeaway tip number 4, you can and should ask for personalized care and be an advocate for yourself. 100%. Again, when you're seeing your provider, make sure that you understand your risk for breast cancer. Again, knowledge is power, and it's really not that challenging to determine your risk. There are so many calculators these days. And so really be an advocate and make sure you're getting what you deserve. Laura, thanks for that. Your MRI is about 4,000. And Vicki, I'm so sorry, your deductible is 9,000. So it's so important to really do the test, do the screening. I know that, again, there are some MRI locations that are cheaper. I believe there's one in Flint, but I probably shouldn't even say that. I have not looked into that in a bit. But it's really, again, shopping and doing your best to be an advocate for yourself. So, here at True, too, for our patients, we have a platform called Mighty Networks, and we really try to keep track of what's going on with people. Our patients share information about where they went, what they're doing. So again, whatever platform you have, to make sure that you're really reaching out, forming a community around yourself and being informed. So tip number 5, again, participating in research helps build a better future for all women. I believe this wholeheartedly. We can't learn if we don't do research, if we don't follow people over time. When I filled out that questionnaire last night, there was a lot of personal information. And one of the risks of doing research is that their database could be breached. Someone could release the information. And I chose to take that risk. If that's the most risk that comes to me from doing this study, if in the realm of things, but again, people doing research have to like, there's so many hoops to jump through. There's the ethics board, there's the conflict of interest form. Like, I really believe that most people doing research are very careful with people's data. They want to be able to do this research and help women, help people. And so they do treat this data with the utmost care, and they're all about informed consent. So if you're at all interested in participating in research, I know there's opportunities here in Grand Rapids, at Corewell, at BAMF, BAMF. There's a lot of opportunities for research. Here at True, we're doing more research around what kind of care works best. How can we reach most women? Looking at menopause and lipedema, looking at menopause and obesity. So we really want to understand how we can help people better. And the only way to do that is through research. Okay, so let's say you're not a patient here at True and you're out in the world, you're far away. What questions can you ask your provider? So these are things that I want you to think about. I want you to make sure you're getting the answers to this. And number 1, always, what is my phase of ovarian function? We know that breast density changes, especially in the late reproductive phase. In perimenopause, people's breast density could change with the roller coaster of estrogen that goes up and down. And in menopause, if you choose not to take MHT, or you can't, it wouldn't be safe for you, we know that your breast density will decrease. Does estrogen increase breast density? It does not if it's bioidentical and you're with bioidentical progesterone. So there are several studies that show that whatever your breast density is at menopause, when you start to take menopause hormone therapy, your breast density will stay the same. So you don't have to worry that taking MHT will increase your breast density. So again, it's so important to ask your provider to know, this is my phase of ovarian function and this is what might be indicated for me. All right, number 2, I want you to be able to ask your provider, what is my personalized risk for breast cancer? How often do I need a mammogram based on my individual risk? So again, we think about cancer in the sense of no one wants cancer, of course. So if you don't want cancer, like, are you doing everything you can to avoid it? And so it's important to know, what is my background risk? And then again, what can I do? what diet would be most helpful. And we know that, of course, a low fat, low sugar, a diet high in cruciferous vegetables like Brussels sprouts, broccoli, cauliflower. We know that all those antioxidants and healthy phytochemicals in those vegetables can potentially reduce the risk of breast cancer. And again, keeping alcohol to 3 a week would be ideal, but for sure less than 7. But again, I want you to be able to ask your provider, how often do I need a mammogram based on my risk? Number 3, ask your provider, do you use risk assessment models like those in the Wisdom study? So again, the Tyrer-Cuzick is one that you can access. The Wisdom study gives you its risk calculator once they take all your data in and give you that information. So again, that's really important to know. Does your provider use a risk assessment model versus just use guidelines, again, that vary by society? So really important to know this. Question number 4, should my screening plan be different based on my history or genetics? So again, if you're not here at True and you're out in the world, I want you to ask your provider, why are you recommending a mammogram every year or every 2 years or every 3 years? Is this based on my history or is this based on my genetics? And question number 5, ask your provider, should I consider genetic counseling or testing? What is the best way to go forward? And again, that's based on family history, or for myself being adopted, yeah, I should probably have genetic testing, which actually I am doing. So it's really important to know. I wish I had done it before, but just, again, it's so hard. There's so many things we're all dealing with. It's hard to make the time, to make the space, to pay the money to get this testing. And so the Wisdom study is a way that you potentially could get genetic testing for free. So this is an important way to think about learning more. I see Vicki is sharing her information. Thank you, Vicki. Been going to Betty for diligent getting care till now. Okay, so I'm so sorry, Vicki, this has been hard for you. And again, if the MRI is not feasible in terms of cost, could you ask about a contrast enhanced mammogram? Could you ask about a molecular breast imaging? So again, make sure you're asking those questions and you're getting everything that you deserve in terms of screening for breast cancer. I can't believe it's already been 40 minutes. So please check us out at truewomenshealth.com. We have lots of information about overall care for women. We so look forward to meeting you if you choose to get your care at True Women's Health. We also have an online course that you would be able to access, and certainly check out the wisdomstudy.org. Learn more about the study. And again, if you choose to sign up, that would be really helpful for all of us. Or if you're able to donate, then more people can get screening. So we really recommend you check it out. Thanks so much for tuning in tonight. And I thank you all for being here. Please share this if you're watching this, especially afterwards. Make sure you share on YouTube or Facebook. Share this with someone else that they might learn the information and get screened themselves. All right. Stay well. Take care, everyone. Thank you.